Hey everyone, I'm your host Anthony. We do content like this weekly, so hit the subscribe button and ring the bell to get notified. If you want more content like this, click the like button and please leave a comment. Thanks again for watching. Hey everyone, and welcome to our live class. We're so excited to have you here today, and we're looking forward to a great lecture. My name is Anthony, and I will be your host. I'm joined on the line by Dr. Julia Malkowski, Scientific Support Specialist at Doctors Data, and virtually by Dr. David Quig, Vice President of Scientific Support, who will be conducting most of the presentation today. I'm going to pass it off to them momentarily to kick off today's topic on GI360, extensive assessment of the GI microbiome. So I think we're really all excited for this one. I'm sure we're going to be learning a lot here today. I'd like to go over just a couple housekeeping items before we begin. I've muted everyone by default. And secondly, if you have any questions during the course of this live class, please submit them into the chat panel. The questions will come to me as the host, and I will be conducting a live question and answer with Dr. Malkowski at the end of today's presentation. With that being said, I'd like to hand it off to Dr. Malkowski and Dr. Quig to begin today's presentation.
Thank you so much, Dr. Kofasi. Yes, and thank you for attending our presentation today. We're so excited to discuss the fascinating gastrointestinal microbiome and the amazing implications with testing. So let's begin.
Good day all, and welcome to this webinar provided by Doctors Data. Today, we're going to take a quick walk through the GI360 stool test with focus on the laboratory methods that we utilize towards evaluation of your patient's gastrointestinal microbes. So why the focus on specific laboratory methods? Well, to be honest, to date, no single approach truly provides all of the clinically important information that today's astute clinicians are demanding. So, being realistic, Doctors Data utilizes a combined complementary approach to fill in the gaps inherent to even the latest and greatest space age technology. So let's begin with a summary of what the GI360 provides. The GI360 provides a very in-depth analysis of the gastrointestinal microbes, the yeast, the bacteria, the parasites, the viruses, using complementary methods, molecular, standardized PCR, state-of-the-art culture with proteomic identification, microscopy, ova and parasitology, and the novel and clinically validated Dysbiosis index. We also provide extensive stool chemistries and biomarkers and direct susceptibility testing for bacteria and yeast. So let's take a look at the pros and cons of the different methods that we utilize.
Excuse us, everybody. It looks like we're having a little bit of audio here issues. And just to recap, Dr. Quig actually was out with a personal emergency. He was not able to make it, so that's why he's here virtually for today's live class. So he'll be presenting the initial portion of the class, and Dr. Malkowski will be presenting the second portion on all of the case studies really pertinent to this class. So it looks like we'll get the audio here back up in just a second. So bear with us. Thanks so much. Dr. Malkowski, if you'd like to try to replay the video. All right, it looks like we are having a couple audio issues here. It sounds like, unless I am being mistaken here, Dr. Malkowski, if you'd like to jump back in just so we can confirm on that.
Yes, hello.
Hi, I just want to clarify, confirm, looks like we may be having some audio difficulties today. Can you hear it on your end? Just want to confirm that we are all there.
Yes.
Okay, cool. All right, feel free to begin the video again. Just want to confirm.
All right, thank you.
PCR is awesomely sensitive. Problem is, it asks the question, is it there? In other words, you're only going to find what you have a PCR probe for. The probe sets are often commonly very limited in scope. And very importantly, PCR cannot provide susceptibility guidance that requires viable organisms, not just pieces of DNA. At Doctor's Data, we use highly standardized PCR platforms to ensure highly reproducible results. We use two different PCR platforms. One is FDA approved, that's for the GI pathogens, and the other is CE marked, a platform that was developed by researchers in Norway. So let's talk about the pros and cons of the complementary microbiology, the culture. We use multiple culture conditions for imbalanced, dysbiotic, pathogenic bacteria, as well as yeast. And we then identify the microbes via proteomic analysis, that is the laser-based MALDI-TOF MS. So unlike PCR that asked, what is it there? The culture asked, what is there? What is there? We're throwing a broader net. And there we can identify the non-targeted, that is the non-PCR-based bacteria and yeast. And today, the reference library that we use with our proteomic analysis contains over 1,400 different genera and species of bacteria and yeast. And that allows us to detect the less common emerging pathogens. We've seen several cases now of the heretofore not reported Laribacter hongkongensis in the US, and also Helicobacter canis. No probes for those. We wouldn't have found those without the culture and MALDI-TOF. Also, very, very importantly, culture enables direct susceptibility testing. That requires live organisms expressing their genetic and their phenotypic expressions. The cons, absolutely. Most strict anaerobic bacteria are not routinely cultured. Hence, you fall back to PCR for those. So for parasites, we use PCR and microscopy. PCR is absolutely more sensitive, but again, very limited in the number of probes that one has. Microscopy over in parasitology, therefore, offers a greater breadth of analysis for parasites. Also, if you're not looking under microscopes, you're not going to see those red blood cells, white blood cells, Charcot-Leyden crystals, and mucus. You're just not going to see those things if you're not looking. Now, let's go to page 1 of the report. Let's start our walk through the report. We start out with a very focused view of the microbiome abundance and diversity. And we use a very well-defined set of probes targeting the most clinically relevant bacteria. So we use 45 targets covering the 6 primary phyla. That's inclusive of 36 genera and 356 species. The results are compared in an unprecedented manner to a reference population of 1,100 observations. So we have a very, very large database for normal biosis. So what we do is we plot the results from the probing of the patient's microbiome on a hexagon indicating the 6 primary phyla. And then in the center here, you see this white spot that we call the web. In this case, it's the results for the patient, a very, very healthy patient. And we call that the sweet spot because it falls right in that green zone. So if you look at the key, the green zone is 0 deviations from normal biosis, well, 1 standard deviation high, 2 standard deviations high, 3 high, and likewise towards the center. So we're basing everything on a very large normal biotic reference population. Now, from that PCR data, we can algorithmically derive a dysbiosis index that has been highly validated in several publications. Now, this dysbiosis index or score, called an index, ranges from 1 to 5 and a score or index of greater than 2 is considered dysbiotic. So the higher the dysbiosis index, the greater your patient's deviation from normal biosis. Again, based against a large number of observations. Now, on the first page, we continue on down and we highlight all the key findings in the report. First, all the key findings from the 45 probe targeting of the microbiome, so listed in importance, 2 and 3 standard deviations from norm. We also provide a summary on the first page of all the rest of the significant abnormal findings in the rest of the report. And that would be from microscopy, be from culture, be from the GI pathogens panel. Okay, so all of these components are not included in calculation of the dysbiosis index. So we really have a test within a test. The dysbiosis test is a test within a test, quite a bonus. So if you want to dig further, in the next several pages, we have all the detailed data for that probe analysis of the microbiome, again, reported as deviations away from normal biosis. Again, based on that large healthy population. And, you know, some people like to really dig deep in here. To be honest with you, I get most of the information I get, clinically relevant information I get, is from the web and the dysbiosis index and the key findings. A lot of people like to dig into these interesting species, but keep in mind, not all of these bacteria are very, very well defined with respect to what they might even do. So we give the option to dig deeper if you want, or just stick with the basics. For gastrointestinal pathogens, we use PCR, and this is an FDA-cleared PCR platform that detects the most common viruses, bacteria, and parasites that are associated with diarrheagenic disease. For parasites, again, to complement the limited number of PCR probes, we use the microscopy, looking at protozoa, tapeworms, flukes, and roundworms. For microbiology, we culture out and look at the pathogenic bacteria, the imbalanced bacteria, and of course, the yeast. And it's really important to appreciate that all of these fields here are expandable. So, for example, if we found Larry, my friend Larry is a pathogenic bacteria, it would be included in this expandable panel. Likewise, if we had 10 different imbalanced bacteria, they would be listed here. And for the yeast, here we have 3 different species of yeast, but do appreciate that we can identify up to 180 different yeast species, including 86 species of Candida. So for this case, of course, we do susceptibility testing on bacteria and yeast. And in this case, we're looking at susceptibility of this patient's Candida albicans to natural botanical agents as well as pharmaceutical agents. Your choice how to go. And then finally, we're looking at very important stool chemistries, the digestion and absorption markers, very importantly, inflammation, the immune function of the secretory IgA, that first line of defense, and of course, the short chain fatty acids indicative of the metabolism by the overall microbiota. And then, of course, pH, beta-glucuronidase, and then occult blood. So my takeaways are really quite simple. The complementary methodologies that we use provide the most clinically relevant consensus of your patient's gastrointestinal microbiota. Standardized PCR platforms yield highly specific and reproducible results. The dysbiosis index provides a rapid identification of deviation from normal biosis. Stool chemistries round out our analysis of microbial metabolism and gastrointestinal health. And all of the key findings are summarized and thorough commentaries are provided for all abnormal results. So for more information, the GI360 reference guide and numerous publications regarding the dysbiosis test, you might want to visit GI360.com. So I turn it over now to my colleague, Dr. Julia Malkowski, who's going to present some interesting case reports. Take it away, Julia.
Thank you very much, Dr. Quig. I sincerely appreciate that. And again, Dr. Quig does send his regards. We appreciate as well every attendee and appreciate your patience with the technicalities today. All right, so let's take a moment now to look at some interesting cases. And here's clinically where we get some amazing insights, all right? So we'll review 2 GI360 cases today. We'll walk through these cases and hopefully you will walk away with a better understanding of stool testing. All right. The first case we have here is for an individual that was actually under the care of a functional medicine psychiatrist. And this patient had presented to his psychiatrist with a chief complaint of lifelong depression and obesity. The obesity and depression really began in late adolescence, and this is really the patient's primary health concern, bringing him into the psychiatrist's office, all right? And fortunately for this patient, his psychiatrist had been studying functional medicine and decided to try stool testing. So we'll see what happens. All right. For this patient here, again, struggling with obesity, and I'm sure you have many patients who have struggled with obesity for quite some time. This patient decided to take it upon himself to switch away from the standard American diet, which is, as we know, tends to be characterized by processed foods, excess fats, excess dietary proteins potentially as well. And so the patient moved away from that and was able to actually lose 20 pounds. This is about 1/4 of the goal weight loss here, okay? So that's pretty good. And then a recent significant history, including 3 rounds of antibiotics for H. pylori. And that might be something you see in your clinic quite often, H. pylori as well. So this might be something that you see. So here we see this patient's GI360. Here's where we get to take a look under the hood and see what's happening with regards to the gastrointestinal microbiome. So let's walk through the setup. This is the first page of the report here. And like Dr. Quig had explained, this first portion here is going to be a web. And the web is an individualized representation of your patient's microbiome superimposed on the normobiotic reference range. Your patient's result is that white webbing there, and the green hexagon is the normobiotic reference range with regards to abundance and diversity. So this is an excellent tool here. Most people actually are visual learners, so this is a great tool to show your patient exactly individualized medicine here. They have their web and it's superimposed on the reference range, okay? So the web is a representation of abundance and diversity by phyla. And here we see the main phyla, like Dr. Quig discussed, the actinobacteria, the vermimicroba, tourniquets, proteobacteria, firmicutes, bacteroides as well. So the key points here are going to be the hexagonal shape is going to represent diversity, and then the size actually represents abundance. So sometimes you'll see the reports really pulled in, and that shows really low abundance. That's not the result here. We do see a disruption in diversity. So that's where we're going to start. There is a disruption in diversity for this patient. The next piece of information we have is the dysbiosis index score. Scores go from 1 to 5. 1 and 2 are healthy, normobiotic guts, and then 3, 4, and 5 are associated with dysbiosis in severity. So the patient here represents with a score of 5. And recall, chief complaint is obesity and depression, almost lifelong. So this does go along with the potentially the history of consuming standard American diet, etc. So that's the beginning pieces of information we have here. Then with the key findings, we can really delve into the details of the microbiome with regards to specific species that are the constituents of the gastrointestinal microbiome. And then we can also look at other components of gut health overall, such as fat stain, short chain fatty acids, inflammatory markers, immunology, and that will be in the second column here. So for the key findings, we have two columns. The first column is the bacteria that have significantly deviated from normal biosis to create that dysbiosis index score, and that's also represented in the web. So for this patient, we can see there's quite a few bacteria that have deviated from normal biosis, and that is contributing to the dysbiosis index score of 5. And so here we see why the patient has a dysbiosis index score of 5 exactly. These are the specific bacteria, and then we see some short chain fatty acids and immunology imbalances. Okay, so for this very first part here, for the key findings, let's talk about these bacteria. The first species we see is the Diaster invistus and the Megasphaera micronuformans species. This species are actually associated with endodontic pathogens. Although this isn't a test for oral cavity microbiome, we could consider that here. We could consider the implications. We can think about the fact that the patient has a history of a standard American diet. We can consider how that might impact the oral microbiome and the gut microbiome together. All right. And just of note, I've seen this elevated too in patients that have recently had dental fillings. So interesting part there. The next species we have is the Parabacteroides. These are very high. These species actually like to consume a high fat diet. So we see these quite elevated in patients that are consuming standard American diet. It's positively associated with obesity as well. So that is going to be presenting with the patient. We do see the Eubacterium cereum is very low. This species is actually potentially associated with excess dietary protein. So we're really seeing here how the microbiome is based on the patient's diet, the standard American diet here. The next species we have is the fecal bacterium protenitzii. Now, this bacteria is quite fascinating. It is a keystone bacteria within the human colon. We're learning a lot about this bacteria now. It is highly coordinated with decreasing inflammation. It is associated with mucosal barrier integrity, and it is also associated with depression. So when it's low like this, patients diagnosed with major depressive disorder, actually this has been noted. So we can see the patient's microbiome makeup here really does coordinate with his chief complaint. Then we see the actinobacteria is low. Those species we really think of with vegetables. So they're going to be low in patients that aren't consuming vegetables. All these types is low. And then the proteobacteria is high. That's an inflammatory bacteria associated with the standard American diet, etc. All these types underdonkey is low, and then the Bacteroides fragilis is too high. So Bacteroides fragilis we typically think of as a healthy bacteria. It's just when it's too high, that is too high. So again, microbiome abundance and diversity is overall, this is a key, okay? The Escherichia species, again, too high, associated with a standard American diet. So when we really take a look at the key findings for this patient, we can see there are bacteria that are strictly associated with the history of standard American diet, as well as major depressive disorder. So this is an excellent test to really begin to assist your patient from a functional standpoint, okay? The next piece of information we have are the additional findings. So we do see an elevated fat stain for this patient. We do see a short chain fatty acid imbalance. We see the higher propionates, the very low valerates. So again, the short chain fatty acids, these are directly derived from the bacteria. The bacteria ferment the dietary products to create the short chain fatty acids. And so that's directly derived from the bacteria. So those two are connected, intricately connected. Right? Then we do see secretory IgA is elevated. The immune defense within the colon is elevated. This can be elevated actually due to a GI infection. This stays elevated for 4 to 6 weeks after the infection. So here we have a patient that doesn't have a history of infection, but it would be interesting to go through the history again and make sure they didn't have a bout of acute gastroenteritis or food poisoning, anything like that. The other consideration then in the absence of that would actually be maybe a food sensitivity. We are well aware that many of the items on the standard American diet are potentially associated with food sensitivities, eggs, gluten, dairy, etc. All right, soy. So that would be something to consider as well. Okay. All right. So here we have, again, detailed information about the microbiome. So here we're looking at the specific bacteria that have contributed to this patient's microbiome. Again, we know we did see at the very beginning here, those diaster species are elevated. So we're going to think about the oral microbiome here. And then going a little bit further down, we see the Eubacterium serum is very low, associated with excess dietary proteins. We see the fecal bacterium proteinitzii is low. And again, this bacteria, when it's low, we think of inflammation, okay? The Lactobacillus is the next one right below that as well. It's trending low. It's still low within reference range, but this bacteria also produces butyrate. So the fecal bacterium proteinitzii and the Lactobacillus, great butyrate producers, which serves to then decrease inflammation in the colon. So we can see the patient here is going to actually be set up for potentially for inflammation in the colon. All right. So what do we want to do, at this point? I would say definitely we want to talk to the patient about oral hygiene. Obviously, diet. The patient is interested in dietary changes, which is great. So you really have a head start with this patient. And there it sounds like there's some education about diet because they don't want to eat processed foods. So you can just take it a step further here. So with the Eubacterium serum, we would potentially say, look at your dietary protein intake. Standard American diet has too much protein sometimes, so consider that. Fecal bacterium proteinitzii, these bacteria love soluble fibers. So we're going to aim actually for 8 to 10 grams of soluble fiber per day. It's going to be dietary sources would be red kidney beans, lima beans, chickpeas, there's some artichokes, garlics, onions, bananas, and then you could also consider supplements as well. Inulin is a good option, okay? The Lactobacillus species really enjoys cruciferous vegetables, so you'd add those to the patient's diet too, okay? And then we see the rest of the bacteria in the middle look pretty good. Lactobacillus looks good. We see actually a slightly elevated Ruminococcus navis. In that case, we're going to talk about mucosal barrier integrity. Of note here, GI360 is not a direct test for mucosal barrier integrity, but we can actually get excellent clues here based on specific bacteria that strongly contribute to mucosal barrier integrity, because that is the predisposing factor to intestinal permeability. And the Ruminococcus is actually one of those species. So slightly higher here. This is not a primary concern in this case. This is like a tertiary concern in the back of our heads, mucosal barrier integrity, because we have really strong indications here of other factors. All right. And the last species we see here a little bit higher, the Vianella species. That species actually produces propionate, and this patient does have higher propionate. So we talked about a short chain fatty acid imbalance for this patient. So we can see that that is directly derived from the dysbiosis here. So putting everything together, we do want to advocate here for soluble fiber at 8 to 10 grams per day. We're going to add vegetables. We're going to add vegetables in general for the actinobacteria. We're going to add cruciferous vegetables for the Lactobacillus. We're going to consider oral microbiome health. And then we're going to also put in the back of our minds, maybe consider mucosal barrier support. All right, here we have the stool chemistries, and this is a fun page because really there's a wealth of information on this page here. The first piece will be digestion and absorption. And here we're going to look at elastase. So elastase looks very good for this patient, but then we do see a positive fat stain. So in the case of the patient that has a positive fat stain, we want to consider their diet. So I know you might have patients right now that are doing these fad diets like the ketogenic diet or even the carnivore diet. And quite often these patients will have positive fat stain just because they're consuming excess fat, especially in that ketogenic diet. So just a clinical pearl, something to be aware of, consider your patient's diet. On the flip side of that, you will have occasionally a patient that is strictly avoiding fat. And then in that case, it's always going to be potentially it's always going to be none, because if they're not consuming any fat, there's no way for that to be positive on the stain here. So we always want to look at each patient individually, especially when we're doing a test like this that can be so individualized for your patient, okay? So for this individual, he does have that fat stain positive. So again, we're going to talk about the patient diet as well. And we are going to consider maybe digestive support here, maybe consider gallbladder function. So those are some next steps. The next piece of information we have is carbohydrates, negative. That looks great. And so then for the inflammatory markers, we see lysozyme, lactoferrin, and calprotectin. These are all within range. These are the markers here that we think about inflammation. With lysozyme, this is the non-specific inflammation, and then we can get more specific with lactoferrin and calprotectin with regards to IBS and IBD. But we do see for this patient, for the immunology marker, we see elevated secretory IgA. So we do want to consider number one, GI infection in the past 4 to 6 weeks. In the absence of a GI infection in the past 4 to 6 weeks, we would talk about potentially food sensitivity here. The next piece of information we have are the short-chain fatty acids. Clinically, butyrate is the one that is probably kind of the heavy hitter, the big powerhouse in this group, very anti-inflammatory, and that looks good for the patient here. But we do see some short-chain fatty acid imbalances with the propionate, and recall that is attributed to the Veillonella species and the valerate. At this junction, there's nothing to do, no clinical intervention directly to these bacteria. We're going to address this via the microbiome and the key findings that we found with regards to those specific bacteria. Last piece of information here, we see the intestinal health markers, pH, and occult blood. For this patient, the pH is lower, so definitely a more acidic stool. So adding that 8 to 10 grams of soluble fiber per day is really going to help and improve that as well, okay? So lower within normal limits, but we're going to look at everything together. So let's move on to our second patient here. Here we have a different case. This patient's chief complaint was really hypothyroidism, arthralgia, actually, unspecified, undefined arthralgia, alternating IBS symptoms. So this is self-diagnosed. And how many times have you seen that in your clinic where the patient comes in with a self-diagnosis? And, thankfully there are excellent testing options out there to really help your patient navigate that, okay? Now, the patient's symptoms have really worsened since a trip to Hong Kong in October of 2019. So there was some travel there, and there's some aggravating incidents. Of note, significant history, the patient is on medications, morphine, gabapentin, Edsons, and paracetamol after having a bike accident in June of 2019. So this patient is taking these pain meds, and we want to include this because although some medications, we know exactly how they interact with the microbiome, and some medications we don't. And reality is our patients are going to be on medications. And for the morphine and the gabapentin, it's not exactly known how they will influence the GI microbiome. We do know about the mu opioid receptors on the colon with regards to peristalsis, and that is a consideration. But beyond that, with regards to the specific bacteria, we'll just pay attention and treat each patient individually, actually. So here we see this woman's report. Again, we're going to start with the web here. The visual representation of abundance and diversity. And this is a great place to start with your patients. This patient's result is that white web superimposed on the normal biotic reference range there. So we do see that green hexagon there. So this looks better than the first report actually, because this is closer to a hexagon. But we do see of note at the bottom right corner, this is skewed towards those proteobacteria. And if you'll recall, the proteobacteria are associated with inflammation. So this is a gut that is actually trending towards or pulling towards inflammation. The next piece of information we have here is the dysbiosis index score. Scores go from 1 to 5 again. 1 and 2 are a healthy, normal biotic gut, and then 3, 4, and 5 are dysbiotic. So here we see the patient does have a dysbiotic gut. We have a clue here thinking that there's some inflammation with the proteobacteria. Let's look at the key findings here. again, recall the first column is the bacteria that have deviated from normal biosis to create that dysbiosis index score. And as Dr. Quig said, this part is the test within the test. I mean, it's really a great option to have all of this specific information. And then we have the second column. Those are the additional findings. In this case, we do have some significant additional findings, and really these two beautifully marry together with regards to abundance and diversity disruption, and then as well as we have significant pathogenic findings actually for this patient, okay? So let's talk about the first column first. We do see for this patient, we have very high proteobacteria. Again, these bacteria are associated with inflammation, nonspecific inflammation, diarrhea. Actually, these bacteria are associated with IBS. And so is that what the patient is describing with her symptoms? Perhaps, but then as we'll see, there are additional findings that actually equally need to be addressed, all right? Again, associated with inflammation, high fat diet as well. The Clostridia class are very low. Clostridia are an excellent group of bacteria within the human colon. These are actually the first bacteria to colonize actually after birth and really do lay the foundation for a healthy human colon for life. And they're too low here for this patient. So we do want to increase those. Really adding soluble fiber is going to be important here. The next piece of information we have is the Streptococcus species is very high. That is potentially associated with inflammation. Streptococcus species are ubiquitous within human physiology, but again, it's that abundance issue. It's that when it's too high, right? So when it's too high, we're taking out of balance, it is skewed abundance and diversity. So that's what we're looking at here. The bacilli class is too high. And then we see this Eubacterium serum is too low, potentially associated with excess dietary proteins. Lactosporochiae is too low. And so that is actually going to be associated with inflammation due to the lack of butyrate potentially. And then we see the Streptococcus salvarius and Thermophilus is elevated. And that is potentially just associated with dysbiosis. Again, these are very common bacteria within human physiology, the skin and the whole GI tract. Okay. The Vianella species, this species is too low here. And so again, putting everything together, this is a disrupted microbiome. And really there's a strong inflammatory component here, especially with these high proteobacteria, the low Clostridia, the lower Eubacterium, the lower Lactosporochiae. So we really do see an inflammatory setup here for this patient. Then we look at the second column here, the additional findings, and we see some key findings here. So the first thing we note is Salmonella detected, Giardia detected. So we have that bacteria, that parasite, and then we also have cultured Citrobacter and cultured Klebsiella. So this is excellent information here on the GI360 because we're culturing these bacteria, the Citrobacter and the Klebsiella, and then we're culturing the Salmonella and the Giardia. Just of note here, one of the patient's chief complaints is ongoing arthralgia. The Klebsiella pneumoniae, I have seen it elevated in one case of ankylosing spondylitis, and that there is an association there, and so people are sometimes looking at it for that. It doesn't necessarily apply in this case, but just kind of in the same family there. So interesting note. And then we have the Geotrichum species, that yeast species that is cultured. Very common to have yeast growing within the human colon, but we want to look at it together in terms of the amount of yeast and take your patient individually. Some people present with yeast symptoms at a very low amount of yeast and other people don't. So that's why we have this information here for each patient individualized. And then we do see the elevated lactoferrin. So we definitely are thinking specific inflammation, IBS. And then we also see this secretory IgA is high. So in this case with the secretory IgA, this is actually appropriate because there are things for the body to mount an immune response. So in the presence of bacteria, parasites, even yeast, or viruses, we do want to see elevated secretory IgA because that shows an appropriate immune response. So this is not a case where we're thinking we want to decrease the secretory IgA. We want to address the underlying cause of the secretory IgA elevation, right? And we can see there are definitely significant findings that would be appropriately mounting an immune response, okay? So we want to put everything together. Recall for this patient, really, chief complaint is alternating IBS ever since travel, especially with that Giardia. We're thinking about travel. You know, one of the questions we ask our patients, have you traveled outside the US in the past 12 months? Because we're thinking of things like this. So really, this is an excellent test where we're utilizing the Dysbiosis index score with regards to microbiome abundance and diversity, that first column, along with the traditional identification of the Salmonella, Giardia, and then the culture for the Citrobacter and the Klebsiella and the yeast. Okay, so we have the best of really both worlds in one test, and this is the best way to address this patient, because if you were just looking at the Salmonella or Giardia, excellent, definitely that should be addressed and treated. But you didn't know about the proteobacteria and this underlying inflammation within the patient's colon, you know, you're really only treating part of the picture of the patient. So you want to look at everything all together, and vice versa. If you just looked at the microbiome, you didn't look for these pathogens, you know, you'd be missing part of the patient's picture, especially in this case with these significant findings. Okay. So here we have the pathogens panel, and this is the PCR portion of the test, just like Dr. Quig said. We're looking for these viruses, pathogenic bacteria, and parasites. And on this portion of the test, again, identification is via PCR, and with the Salmonella and the Giardia, really the treatment is going to be standard of care, considering metronidazole, et cetera, because that's what you want to do in this case, right? So we're providing the best information, and that's what to do at this point. So that would be the primary consideration for this patient, especially because she presents with symptoms. You know, just of note here, we do want to consider PCR is excellent. It's highly sensitive and specific, and so sometimes people can be asymptomatic carriers with Giardia and Salmonella as well, and C. difficile. So you want to consider your patient's history and presentation, their symptoms with this part here, okay? So here we then have the culture page. So here's the page where the bacteria have been cultured directly from the patient's sample. So this is excellent individualized information. Those pathogenic bacteria at the top, the Aeromonas through the Yersinia, those are pathogenic bacteria that we're always identifying the absence or the growth of those there. And example, we can see the Salmonella was not cultured, but it was present and is found on PCR. And so that's why we really use PCR and culture together. So it's excellent. And the next part here, we have the imbalanced bacteria. And we see there's 2 species of imbalanced bacteria that's really within normal limits. Then the next piece of information, we have the dysbiotic bacteria, the Citrobacter and the Klebsiella. Those are cultured. We definitely want to address those, the Citrobacter and the Klebsiellas. And then the Geotrichum species, it's too much yeast, actually at 4+. Small amount of yeast is really considered within normal limits in the human colon, and most people do just fine with that. But this is too much yeast. So we have very individualized information here for our patients. And here we see the agents here. So you can use prescriptive or you can use natural agents. It's really your call, like, you know, Dr. Quig said. And this is excellent information. Doctor's data does not use wall charts. So this isn't information that was researched somewhere. This is actually taking the bacteria or the yeast in vitro and putting it with those agents and reporting the information to you. So it's very individualized, and this is really going to help your patients, especially with, you know, that Klebsiella and that Citrobacter. So for this patient, you actually do want to treat the Klebsiella, the Citro, the yeast, and it does sound like the Giardia and the Salmonella as well. Well, thank you very much for your attention today. I really appreciate it. And if anybody has any questions, I'd be happy to go over those now.
Thanks so much, Dr. Malkowski. That was super informative. It's really clear that the GI360 is one of these top stool tests on the market today. And clearly there's a lot of really valuable markers that practitioners can take home for their patients with this. So thank you for covering that. In addition, it looks like we have a few questions that were received during the presentation, and we're going to try to get to most of those now. So let's just jump right into the question and answer. And I will start with the first one. And the first one is, how important could this test be for a child with serious digestive issues?
Yeah, great question. Thank you. Well, yeah, so this is a common question, and I think it's important to consider for children, especially nowadays with everything. And then also there's some research with regards to like a C-section birth versus a vaginal birth, and maybe you want to find out about that right away and you can intervene. So the test is actually applicable to all ages. So you could use infants through any age, really. The markers do apply through all age groups. The one consideration would be collection. So for a child, you want to catch it in that collection tray. If not, if you're taking it from a diaper, you don't want to have any portion of it that's been touching the diaper. So to get from the middle of the sample is going to be the thing. But yeah, this test does apply to children, and I have seen some excellent clinical outcomes in that regard.
Amazing. That's really important. As you mentioned, clear collection. We want the test to be accurate. So very, very good on that. Second question, Dr. Malkowski, is do medications such as immunosuppressants, corticosteroids, and other IBD specific drugs alter these results dramatically? We know you touched on some medications here today, but specifically on this question.
Yeah, great question. And that is very clinically applicable because we do see most of our patients are on medications, right? And especially with the stool test, we want to address those patients that have suffered with IBS or suffered with IBD, and they may or may not be on medication. So really the number one thing we do want to consider there is those anti-inflammatory medications, what they do what they're supposed to do. So they are supposed to decrease those inflammatory markers. That's the pathophysiology, the mechanism of action there. So in that case, we would expect them to be decreased. So it's your clinical consideration. If you want to see what the patient's microbiome looks like without those medications, you can have them refrain from that for 1 week. But if you want to actually monitor treatment progress and see how their microbiome looks like on that medication, you can keep them on the medication. The other consideration is, what is the gut you're going to be treating? If you think the patient, it's in their best interest to stay on that medication, then you might want to look at the GI360 in that regard. You might want to see the microbiome on that medication and make your interventions at that point, at that juncture.
Makes sense. Thank you so much for that, Dr. Malkowski. Moving on to question number 3. Can a low fiber diet make the short chain fatty acids look low? Essentially, so it looks like it's really a dietary issue versus a microbiome issue, trying to differentiate those. The practitioner mentioned that it sounds like they go hand in hand. So low fiber making the short chain fatty acids look low.
Good point. Yeah. So really you can't separate the microbiome from the diet, because it's essentially the constituents of it is the food that you're eating feeds the bacteria, basically. So we do see low fiber diets, that is one of the diets that is out there. And absolutely, I think we did have a case where, that was a contributing factor, the low soluble fiber, potentially contributing to short chain fatty acid imbalances. I mean, I will say we do tend to see low soluble fiber and dysbiosis and low butyrate go hand in hand, which is going to be a predisposing factor to inflammation. So that's definitely something to consider. Potentially low fiber diet might be in the category of a bad diet, like we mentioned briefly, like the ketogenic, et cetera. And you do want to pay attention to those dietary choices, and the microbiome, definitely a good idea to monitor along the way. Yeah.
Great question. Great answer. Thank you for that, Dr. Malkowski. This number 4th question is a probably very common question, but how often do you repeat the GI360 stool test?
Okay, so the GI360 stool test is actually, you can repeat it about every 4 to 8 weeks, and that is going to be considering what the findings are. If you're going to do a antimicrobial treatment, you want to
Alert from system UI server.
my computer is looking
Low
like it's gonna
battery.
die. Sorry about that.
No worries. Take your time in plugging your computer up. For everyone who's joining us here today, again, thank you so much for joining us on today's live class. We hope you have enjoyed it, and we are going to be back here in just a moment. Dr. Malkowski, good to go?
Yes, thank you.
Beautiful.
Okay. So yes, you want to retest, you know, maybe about every 4 to 6 weeks. It depends on the findings. It depends on patient compliance and then the treatment. So if your patient has a dysbiotic bacteria, you know, you want to treat that with your antimicrobials. Maybe you're going to do like 2 weeks or a month of probiotics afterwards, and then you're going to wait 2 weeks after that point. So really between 4 to 12 weeks, I would say, is about average.
Very interesting question. Great question. And so true. Just as stool can change in a very short amount of time and you can retest, so does things like our red blood cells. We know anemias can develop in just 120 days or less. So very important to be retesting the GI360 if you've done on your patients. All right, Dr. Malkowski, last question here is if a patient has positive bacteria in the PCR report, but they do not have signs or symptoms related to bowel movement issues, such as bloody stools, do you still go ahead and treat this?
Yeah, great question. So now we're talking about PCR, which everybody and their mom knows based on the past year. Before it was only our group of people, you know, it was a niche group of people that knew about this. But PCR is highly sensitive and specific. So it picks up the DNA. It can pick up the DNA of a resolved infection for potentially months. So you always want to pay attention to your patient's symptoms, their presentation, their history, right? So in the case of a patient that has a positive, let's say, C. difficile, and they don't present with any C. difficile symptoms, no C. difficile disease, no, you know, history of hospital, anything like that. So in that case, you probably do not want to treat the patient because people can be asymptomatic carriers. There actually is some interesting research that potentially asymptomatic carriage of C. difficile disease contributes to community balance within the community and decreases severe infections. That's just one example, but really you do want to treat the patient. I mean, we did see that case today that had, you know, the PCR data, it was found, and it was not cultured, but the patient was symptomatic. So in that case, you would treat. Does that make sense?
Absolutely. Thank you so much. Obviously, we always want to get to the root issue, but sometimes the root issue is not very obvious or has clinical presentations, as you mentioned. So thanks for diving further into that. So thank you, everyone who submitted questions, and thank you, Dr. Malkowski, for answering all those. I know we weren't able to get to everyone's questions, so if you have further need, please feel free to reach out to us after this live class. Thank you again, though, for attending today's live class. I want to give a huge shout out to Dr. Julia Malkowski, Dr. David Quig of Doctor's Data. This was very interesting and a very helpful presentation in understanding the GI360 and applying it in clinical practice. So thank you again, and we hope to see you all at the next live class.